So after having discussed the topic of arthritis in detail, we are moving to the next topic. The next topic is on vasculitis. Okay, vasculitis. So vasculitis is a very important topic for your exams, and I would say that it is clinically very relevant also. So there is a good chance that you may get clinical integrated questions pertaining to this module. So listen to it very carefully. This is very simple. Okay, so there is no hardcore concept in this, but all you have got to know is the individual characteristics of the various vasculitis that we are going to discuss. So what is vasculitis? It is nothing but the vessel wall inflammation. Okay, the vessel wall inflammation is what you call a vasculitis. Now in this module, first we will discuss about the classification of vasculitis, and then we will discuss individual entities in that. Okay, so classification of vasculitis, it was in 2012. Okay, 2012 that there was a revised classification system, that is the revised international Chapel Hill consensus conference classification. Okay, so this Chapel Hill classification is the one which is accepted worldwide. It was in 2012 that the classification came, and it was published in 2013. Okay, in the official journal of the American College of Rheumatology. Okay, so you can see here the 2012 revised International Chapel Hill Consensus Conference. So that is the classification nomenclature that we are going to learn. So how did they classify the vasculitis? Okay, so the classification of vasculitis was based on what was the predominant vessel that was involved. Okay, I'll just show you a picture from the very same article published in 2013. See, they divided this vasculitis into large vessel vasculitis, medium vessel and small vessel vasculitis. So what were the large vessels as per the Chapel Hill Consensus Conferences? So the large vessel means it is the aorta and its branches will constitute the large vessels. And what about the medium vessels? Medium vessels means it would be the visceral arteries, the corresponding veins, okay, and their initial branches, okay, initial branches of these visceral arteries, because subsequently it would become the small vessels. So the visceral arteries, corresponding veins and the initial branches were considered as medium vessels. And what about the small vessels? The intraparenchymal arteries, okay, the arterioles, venules and the veins, and the capillaries also. Okay, so these were the small vessels. Okay, so they subdivided it based on the predominant affection. Now mind you, I told you they divided into large vessel, medium vessel and small vessel vasculitis, but I will stress on this word predominant affection. So it doesn't mean that all large vessel vasculitis will be entirely restricted to the large vessels. It may affect these medium vessels also. Similar is the case with small vessel vasculitis. You can have small vessel vasculitis may be affecting some medium vessels also. So this classification was based on the predominant vessel that was affected. Okay, so I hope that is clear. So let's see how they classified this vasculitis and what are the individual entities coming under this, because once we see that, we will go to the individual entities. Okay, so this is a picture of the classification of vasculitis into large vessel vasculitis, medium vessel vasculitis, and then you have the small vessel vasculitis, which is divided into two, okay, that we'll learn. So first of all, let's see how did they classify. Okay, So one was the large vessel vasculitis. Large vessel vasculitis, which means inflammation involving the aorta and its branches. The classical example of large vessel vasculitis was the giant cell arteritis, as well as Takayasu arteritis. So giant cell arteritis and Takayasu arteritis are the large vessel vasculitis. Number 2, the medium vessel vasculitis. So what are the entities in the medium vessel vasculitis? You have the polyarteritis nodosa, as well as Kawasaki disease. Okay. So these are the 2 medium vessel vasculitis. And then finally, you have the small vessel vasculitis. Now, the small vessel vasculitis is again subdivided into 2 groups. Very important. So one is the group of AAV or the ANCA associated vasculitis. The ANCA associated vasculitis. Okay. ANCA associated vasculitis. And the next one is the group of immune complex mediated vasculitis. Okay. So in the ANCA associated vasculitis, which you can call the AAV, okay, ANCA associated vasculitis, there were the following diseases which were included in the ANCA associated vasculitis. So ANCA stands for what? It is the anti-neutrophil cytoplasmic antibody. Okay, anti-neutrophil cytoplasmic antibody. Okay, and based on the staining pattern, you know that this ANCA can be a P ANCA or a C ANCA. That is, P stands for the perinuclear staining pattern and C stands for cytoplasmic. Okay, P is the perinuclear and C is cytoplasmic. Okay, alright. So under the ANCA associated vasculitis, what are the entities there? You have the microscopic polyangiitis. Then you have granulomatosis with polyangiitis, which is GPA. Okay, and this granulomatosis with polyangiitis is actually the new term of which disorder? The Wegener's granulomatosis. So it is the old Wegener's that is now referred to as the granulomatosis with polyangiitis. Wegener's granulomatosis. Okay, alright. And then you also have the EGPA, that is eosinophilic granulomatosis with polyangiitis. Okay, and that is EGPA, and this EGPA is the again the new term, and this old term was Churg-Strauss vasculitis. Now you have got to be a bit careful here, because I am sure that many of you are accustomed to this term Wegener's as well as Churg-Strauss. So remember that the terms are now outdated, though for the convenience of discussion we use the terms Wegener's and Churg-Strauss even now, but in the exam the examiner might go for the GPA and EGPA. So always be careful. What is GPA? It is Wegener's, and EGPA is your Churg-Strauss vasculitis. So these are the ANCA associated vasculitis. Okay, and then you have the immune complex mediated vasculitis. Okay, and the immune complex mediated vasculitis, you have the entities of cryoglobulinic vasculitis, Okay, the Goodpasture syndrome, Goodpasture syndrome, the Henoch-Schönlein vasculitis, which is a IgA vasculitis. Okay, it was previously called Henoch-Schönlein purpura, but it is now understood as a vasculitis. Okay, so and also you have the hypocomplementemic vasculitis. Okay, so these are the subtypes of immune complex mediated vasculitis. Now let's go back to the picture. You see the large vessel vasculitis, okay, which is affecting the aorta and its branches. They are the Takayasu and the giant cell, which we have learned. The medium vessel vasculitis, the polyarteritis nodosa and Kawasaki. You have the small vessel vasculitis, which again can be divided into ANCA associated vasculitis, microscopic polyangiitis. Some people also refer to it as microscopic pan. Okay, but do not confuse microscopic pan with the medium vessel vasculitis pan. Granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. Then you have the immune complex mediated small vessel vasculitis, where you have cryoglobulinic vasculitis, then the IgA vasculitis, which I told you is the Henoch-Schönlein vasculitis, and the hypocomplementemic urticarial vasculitis, which is also known by the term anti-C1q vasculitis. So if you notice here in this picture, you see this is the large vessel vasculitis and you see medium vessel vasculitis here. And you might have noticed, see there is an overlap also between the large vessel as well as medium vessel. There can be overlaps, okay, overlaps in the region of vessels that are involved. So always keep in mind predominantly medium vessel is the medium vessel vasculitis and predominantly large vessel is the large vessel vasculitis. And you can see the vessels affected in the ANCA associated vasculitis and the immune complex vasculitis. You can see the anti-GBM disease also. So this large artery, medium artery, small artery, capillaries, venules, veins, okay. Alright, so we have learned the classification. This is one picture that should be there in your mind forever, okay, very, very important. Now you got to know that in addition to the classical subdivisions of the vasculitis, you also have an entity that is called as the variable vessel vasculitis. Variable vessel vasculitis. Now what is this variable vessel vasculitis? It means, vasculitis in which sometimes you might have a predominant large vessel involvement, sometimes medium vessel, small vessel. So the one you could not group into a particular subgroup, okay, a major subgroup, that is what you call a variable vessel vasculitis. And there are two disorders falling under the variable vessel vasculitis. One is Behçet's disease, and the second one is Cogan's syndrome. We will discuss that later. Behçet's disease and Cogan's syndrome. These are variable vessel vasculitis. So sometimes they can ask you a question on which of the following is a variable vessel vasculitis. So this term variable vessel vasculitis is reserved for Behçet's and Cogan's. And another term is there that you should know is the single organ vasculitis, which means vasculitis involving a single organ, because most of the vasculitis that we are going to learn are multi-system disorders, okay. But sometimes you can have a vasculitis which is restricted to a single system. A classical example will be a primary angiitis of the central nervous system. Primary angiitis of the central nervous system, which is also called as primary CNS vasculitis. Primary CNS vasculitis, okay. So you have got to know that, okay. So this is the classification of vasculitis, okay, very clear on the classification. Alright. Now, in addition to this classification which you have got to learn, that is the Chapel Hill Consensus Conference classification of 2012, you must also understand that you can classify vasculitis into primary as well as secondary, okay. So it is the primary vasculitis that I have already told you, okay, the subclassification that we have seen is pertaining to the primary vasculitis, which means the vasculitis per se is the major problem, okay. So under this are the various entities which I have already described, so I am not repeating again. So those are the primary vasculitis syndromes, okay. Whereas you can have secondary vasculitis in which vasculitis is there, but there is some other disorder, and secondary to that disorder you may also have a vessel wall inflammation, which includes a drug-induced vasculitis, vasculitis related to hepatitis C infections, hepatitis B infections, then SLE, rheumatoid arthritis, sarcoid. We have already seen in the connective tissue diseases that these can cause vasculitis. Okay, so they are secondary vasculitis. Okay, so I hope that part is also clear. Now we have understood in detail regarding the subclassification of vasculitis. Now let's go to the individual entities, which are very, very important. Each of this is a potential question. So right from the first disorder I discussed to the last one, please pay attention. Okay. So the first disorder, we'll start with the large one. Okay, we'll prefer the large ones first. So discussion will start with the large vessel vasculitis, and I'll take my personal favorite here to discuss the giant cell arteritis. Okay, giant cell arteritis. So giant cell arteritis. Okay. So this is a vasculitis that is predominantly seen in the elderly population. Okay, this is predominantly seen in the elderly population. So the age group of presentation is almost always above 50 years. Okay, so in fact the mean age of presentation would be around 70 years. Okay, so but always remember it is above 50 years, and females are more affected than males. Females more affected than males. Okay. Alright. So this entity giant cell arteritis is having certain other names also. What are they? It is also referred to as the cranial arteritis, temporal arteritis, cranial arteritis, temporal arteritis, and previously it was also given a name, granulomatous arteritis. It is not used now. Okay, granulomatous arteritis. Okay, so these are some of the other terminologies for your giant cell arteritis. Okay, so what exactly happens in this disorder? Okay, what is the etiopathogenesis? See, here again, we are not very sure on what is the inciting event. Okay, and but there is a definite HLA association, that is, you have a HLA DR4 association. This is important, it may be asked as a question. There is an HLA DR4 association. And remember that the pathology of this disorder, okay, when you talk about the etiopathogenesis, what happens is actually a panarteritis. Okay, though we do not know what incites this event, we are quite sure that this is a disorder that involves all the vessel walls. Okay, the entire vessel wall, that is intima, media and adventitia. But though it is a panarteritis, the disease is initiated okay, it starts in the tunica adventitia, okay, but definitely the media as well as intima also can be involved. Okay, you can have a disruption of the internal elastic lamina, you can have an increase in the thickness of the tunica media, all this is possible. So this is a panarteritis. So let's actually see what happens in this disorder, okay, with a simple diagram. So most of the pictures that I will be showing you in this particular module have been taken from Kelly's textbook of rheumatology. So in case anybody is having an interest, you can read Kelly's textbook of rheumatology. Okay, so it is actually the standard book of rheumatology. So after medicine, if somebody is interested in a super specialization, they can even go for a super specialization in rheumatology and immunology. So this is a very interesting branch also. Okay, though in undergraduate days we do not have much exposure to this branch, but this is actually a wonderful branch. Good treatment responsive diseases are there. Okay, and even for those who are interested in research also, there are opportunities. So let's see the pathogenesis. First step is antigen recognition in the adventitia. That is what we do not know, what exactly is the antigen, but again I told you the disease is initiated in the adventitia, and subsequently there is interferon gamma production, and then what happens is that there is a differentiation and functional specialization of the macrophages, because they would sometimes transform to cells of the smooth muscle phenotype. And then what happens is that there is formation of giant cells. Okay, and in this there is an important role for the matrix metalloproteinases, growth factors, angiogenic factors, all are important. Okay, and then what happens is that there is tissue destruction. Okay, tissue destruction, and there can be matrix degradation and lipid peroxidation, subsequently resulting in the arterial wall disruption. Okay, and there can also be a remodeling process which is characterized by cellular proliferation as well as proliferation at the extracellular matrix level. And then what happens is that the thickness of the media actually increases, and there is a luminal compromise that happens. Okay, there is a luminal compromise that happens. So this results in an occlusive intimal hyperplasia, and subsequently you get the manifestations of giant cell arteritis. So you see how the disease has started in the adventitia and subsequently involves all the layers of the vessel wall, being a panarteritis. Okay, so that is also very clear. So now we go to the clinical features of giant cell arteritis. Clinical features. So clinical features of GCA. The most common clinical presentation of GCA is with headache. Okay, is with headache. Okay, which is the most common symptom. Patients may also have other features, like you may have jaw claudication. Okay, headache may be there, jaw claudication may be there. Patients may have systemic features also, like you may have fatigue, okay, myalgia. Some patients may have fever, okay, and may even present with a pyrexia of unknown origin. And then you might have vague stiffness in the neck, your shoulders, your hip, your waist, lower back. This is known as polymyalgia rheumatica. Polymyalgia rheumatica, where you have stiffness involving your neck, shoulder, lower back, hips and thighs. So remember, polymyalgia rheumatica is a disorder, it's abbreviated as PMR. Remember that this is a disorder not exclusively limited to your giant cell arteritis. Okay, it can be a separate disorder by itself, but around 40 to 50% cases of giant cell arteritis would have associated polymyalgia rheumatica. Okay, and one of the dreaded complications of your giant cell arteritis is visual loss. Okay, visual loss. That the visual loss occurs because of the AION, that is your anterior ischemic optic neuropathy. Okay, so that is one of the dreaded complications. So I told you, though it is predominantly a large vessel vasculitis, it can affect some of the smaller vessels also, like your posterior ciliary artery. Okay, so subsequently the optic nerve perfusion also may be affected. But always remember, this is a large vessel vasculitis. And see, I told you large vessel is the aorta and its branches. But per se, a pure aortic involvement is seen only in 25% of GCA will have aortic involvement. So more often it is the branches of aorta that is involved. Okay, because the other large vessel vasculitis that we are going to learn, that is your Takayasu arteritis, is having a better predilection to involve the aorta. Okay, alright. So these are the clinical features of the giant cell arteritis. Okay, so let's just see the giant cell arteritis, some important images. So you see here, I told you this is called a temporal arteritis. So always know that the common vessel that is obviously involved in a giant cell arteritis is going to be a superficial temporal artery. And remember that the superficial temporal artery in your giant cell arteritis, the vessel is actually dilated and tortuous. So dilated, tortuous temporal artery, and it is very much tender on palpation also. It is tender on palpation. Okay. So always keep this image in mind, especially when you have an elderly patient presenting with headache as a clinical scenario. This is one disease you have got to suspect, okay, but never suspect this patient, giant cell arteritis in a patient who is say 25 years of age with headache, okay. So the age group is very, very important in a giant cell arteritis. And coming to the symptoms of giant cell arteritis, we have already discussed. The most common one is headache. I told you there may be symptoms like fever, weight loss, fatigue, visual symptoms, anorexia, jaw claudication, polymyalgia rheumatica, arthralgia, visual loss which can be unilateral or bilateral, vertigo, diplopia, okay. But the initial symptoms like headache, jaw claudication, polymyalgia rheumatica, visual symptoms, these are the ones the examiner is likely to put in the clinical scenarios, okay. And in the examination, one of the findings that you will definitely demonstrate is a palpable tender temporal artery, and you will have a scalp tenderness also. Patients with the giant cell arteritis may also have a scalp tenderness. So this is an image of a patient who with giant cell arteritis who developed AION, anterior ischemic optic neuropathy. So you can see the disc is very much pale and swollen. You can see some areas of hemorrhage also which can be appreciated, okay. So that is AION. So that also can be a clinical presentation. And when there is a AION, you might have learned in your ophthalmology lessons that it characteristically produces a altitudinal visual defect, okay. Characteristically produces a altitudinal visual defect, which means in the visual field they might not be able to appreciate one part. Sometimes the patient might say that, doctor, I am better able to see the lower part of your face, the upper part I am not able to see well, okay. That is what is called a altitudinal field defect, okay. Alright, so now coming to the criteria of giant cell arteritis. So before coming to the criteria, I'll just tell you the investigation findings as well. So the investigation findings is that giant cell arteritis, I told you clinical suspicion is very important, but again the lab values can be supportive. You can have elevated values of your ESR, okay. ESR is elevated, sometimes more than 100, but most often above 50 for sure, but many cases you can have values above 100 also. And this is again very important in the workup of a patient with giant cell arteritis, because if the patient is presenting with a symptom, an acute symptom, more often than not you will have a elevated ESR levels. So the next point that you have got to keep in mind is that in addition to the elevated ESR, you might have when you do a ultrasound, okay, when you do a ultrasound of the temporal artery, you will get especially the duplex scan, ultrasound duplex scan, where you are visualizing the vessels also. So you get a particular sign that is known as the halo sign, which I will be showing you the image. The halo sign is there. But always remember what is the investigation of choice. If you want to diagnose, or the gold standard, that is going to be the biopsy, and the biopsy is going to show a panarteritis, okay. So biopsy is going to be the gold standard if you want to diagnose giant cell arteritis, okay. So now let's come to the criteria, okay. The criteria that I am going to show is the ACR criteria, okay. So I am sure that after the rheumatology lessons, you would be cursing your ACR, as well as then you have the European League Against Rheumatism, okay. So they are the ones putting all these criteria. So you will have a few criteria in this module on the individual disorders. You need not by heart this criteria, but I would say this is for you to understand, okay. That is, in your exam, when a clinical scenario appears as a question, when do you suspect this is a case of a giant cell or a Takayasu? You have got to know that, okay. So because whenever there is a criteria, the body who has formed the criteria, they would be focusing on the most important points of a disease, or the cardinal manifestations of a disease. You cannot frame a criteria for a particular disease based on the rarest of rare manifestation of that disease, okay. So age of onset more than 50 years is one criteria, okay. So that we have already discussed. New onset headache. See, suppose if somebody is having a headache from 20 years of age and probably is already diagnosed as having a migraine with classical symptoms, and if he is having a relapse of the various symptoms and comes at around say 56 years with another migraine episode, Just because he's above 50 years and he's having a headache doesn't mean this is anyway a giant cell arteritis, because his headache has been there for long. But if it is a new onset headache in an elderly patient, then you must suspect giant cell arteritis. Temporal artery abnormality, yes, you can have a tender temporal artery with decreased pulsations. Okay. Now, if you ask me, the most common vessel I told you involved is a superficial temporal artery. Then if you ask me, sir, what about the intracranial vessels? Okay. Remember, the intracranial vessels are less often involved compared to your extracranial vessels. Your superficial temporal artery is an extracranial vessel. It is more involved than an intracranial vessel, which is why, though it is a large vessel vasculitis, presentation with a myocardial infarction or a stroke, not myocardial infarction, presentation with a stroke is rare. Even myocardial infarction is also rare, but the point I wanted to highlight is that the intracranial vasculature involvement is very less compared to a extracranial vasculature involvement. Okay, and elevated ESR, which is again another important finding, and abnormal biopsy. Okay, that again is very important. Now, when you take a biopsy in case of giant cell arteritis, it is always necessary that you should take a long specimen. Okay, a long specimen, because there is always a chance of skip lesions. Okay, there is a chance of skip lesions to develop in case of a giant cell arteritis, which means if you are taking biopsy from a particular region, see, if you take a very small section, there is a high possibility that that particular section may not be involved at all. Okay, so you should be very careful with respect to the biopsy. You should take an adequately long specimen of around 3 to 6 centimeter, and this long specimen is taken because there is always a possibility of a skip lesion. Otherwise, you could have taken a very small section. Okay, so when possible, you take a longer section for your biopsy. Okay, so that should be clear. So that's it about the diagnostic criteria, and this is the biopsy of a patient with a giant cell arteritis. You can see it is flooded with inflammatory cells. Okay, it is a pan arteritis, and this is a temporal artery biopsy. Lots and lots of inflammatory cells you can see in giant cell arteritis. Okay, and this is very, very important. Again, I told you sometimes they'll put a picture of a dilated temporal artery or a biopsy picture in the image based scenario. So they can put in any way, in this chapter. That is why I always say that rheumatology is more about images. See, the American College of Rheumatology, in their website there is a separate image bank. Okay, image bank where you have lots and lots of images of rheumatology. If you are interested, you can go through, but it is a paid subscription. But it is, they have a good collection of all the images. Okay, so that is why, always the images that I have shown in these modules when I have discussed rheumatology, please revise them periodically. Okay, so this is your the pan arteritis and inflammatory infiltrate in the biopsy of a patient with giant cell arteritis. And any guesses on what this is? This is a duplex ultrasound finding, which is referred to as the halo sign. Okay, so halo sign, what does it mean? If you can see at the center, you can see the redness, correct? And can you appreciate that there is a region of halo around the red region is where your blood is actually flowing. And because there is so much of wall thickening in case of giant cell arteritis, there is an appearance of a halo around the actual lumen, which is compromised and through which the blood is flowing, and around that you will notice a halo. So this is the halo sign in case of your giant cell arteritis. Alright, okay. So you have seen what this entity is, what are the clinical features, how to diagnose it, what are the supporting investigation findings. Now let's go to the management part of giant cell arteritis, the management. So management part of giant cell arteritis, I'll just show you this table from Kelly's rheumatology textbook on the systematic way of managing a patient with giant cell arteritis, and here I will like to discuss a controversy also with you, okay, which many students ask me. See, once giant cell arteritis is suspected, okay, suppose you are suspecting giant cell arteritis, the first and foremost question, that you should answer is there any visual loss or not? Because that is again a threatening complication of giant cell arteritis. So you have got to check whether there is visual loss. Now, if there is visual loss, then you have got to be aggressive. So then you have got to be aggressive means you have to put the patient on steroid pulse. So solumedrol, that is your methyl prednisolone, 1 gram IV for 3 days. Okay, you have got to give a pulse steroid. That is very, very important. Okay, so now comes the question. Often students ask me, sir, if there is a visual loss in a patient with giant cell arteritis, should you not go for biopsy first and confirm the diagnosis and then start steroids? Because there is often a clinical question being asked like that. See, the guidelines say that you must aggressively treat if there is a visual loss. See, if you're planning for a biopsy, just use your common sense. If you want to, suppose your patient is admitted today in your ward and you're suspecting a giant cell arteritis in an elderly female with a headache, dilated tender temporal artery with a visual loss also. See, you are almost very sure that this could be a giant cell arteritis. Now, if you wait for a biopsy, you've got to get a date from the surgeon and he has to be posted for surgery, and the surgery has to happen and the specimen has to be sent for the biopsy, and you have got to get the results. You think of the delay that can happen. Definitely at least 2 weeks delay will be there, to get the final report, correct? So, which means if you are suspecting a visual loss, please do not delay, start steroid pulse. Nothing bad is going to happen with a steroid pulse, but what are you trying to save? The visual acuity of the person. Okay, otherwise, you might be permanently blind. Okay, now if the patient is not having a visual loss, then you can start the patient on oral steroids. Okay, 1 mg per kg, roughly around 60 milligram or 50 milligram you can start off with, and you start the patient on steroids, and then you can go for a biopsy. Okay, so if the biopsy is showing an evidence for giant cell arteritis, you can continue with the steroids. You can subsequently taper the dose of steroids, because what happens is that, see, I have a patient with giant cell arteritis. I have started on 60 milligram prednisolone. Okay, so 60 milligram of prednisone I have started this patient, and maybe after a couple of weeks I'll think of reducing the dose to 50, or maybe after 1 week I'll think of reducing to 50, and then slowly 40 milligram, 20 milligram, like that. So you have got to slowly taper off the steroids. And mind you, when you taper off the steroids, there is always a possibility that the disease activity can flare up. Okay, so in that case you will somehow have to increase the dose of steroids. Okay, so it is always a trial and error, where you are trying to decrease the steroid dose and watching out for the disease activity. And ESR is one tool that can help you, okay, in monitoring the disease activity, because the declining value of ESR is an indirect clue. Okay, though not with 100% surety, but almost an indirect clue that the patient is responding. Okay, so ESR values can be periodically checked, and then you slowly reduce the dose of drugs. And if you ask me, how long should you treat? Is it a lifelong treatment for steroids? See, most often the patients would require treatment for 2 years. Okay, most often. And after that, it depends on the treatment response. There may be a subset of patients in whom the symptoms have almost resolved, in which you are able to maintain at a very low steroid dose, or maybe no dose at all. But some individuals may require a prolonged therapy, especially those in whom, when you try the steroid taper, again the symptoms are recurring. Okay, so that should be taken care of. Now, another important question that you might get is, see, if a patient you have started on steroids and the biopsy result has come out to be a case of giant cell arteritis, another drug that you can try is tocilizumab. Okay, tocilizumab. This is important because in 2017, this was FDA approved for the treatment of giant cell arteritis. Okay, 2017 it was approved, and so this is another drug that can be and be asked as a clinical question also. So you can go for tocilizumab and subsequently taper the steroid dose, because naturally there are problems with long-term use of steroids as well. Okay, so that the use of tocilizumab is not in all patients with giant cell arteritis. Is often done when the patient, or is given when the patient is having higher risk of developing complication, which means, say, is having persistently high ESR. you're trying to taper the dose of steroids, again there is a flare up of disease activity. In such patients you can add tocilizumab. But if the disease is very well responding to your steroids, then you need not add tocilizumab. Okay, so this is how you will manage a case of giant cell arteritis. Okay, very clear on this? Okay, so let's move to the next entity in the group of the large vessel vasculitis. And what is it? Takayasu arteritis. Takayasu arteritis. Okay, Takayasu arteritis. So Takayasu arteritis, compared to your giant cell arteritis, which is predominantly seen in elderly and slightly more in females, here also it is more in females with a higher female to male ratio than your giant cell arteritis. So this is affecting your young to middle-aged females. Okay, young to middle-aged females are the ones which are more affected. So younger age group of presentation is there with your Takayasu arteritis is highly likely in case of females. Okay, so this is also a large vessel involvement. But remember, the commonest vessel that is involved in Takayasu arteritis is a common question in entrance exams. So there is a chance that students may get confused, primarily because of one reason. The Takayasu arteritis is also referred to as aortic arch syndrome. Okay, it is also referred to as non-specific aortoarteritis. Non-specific aortoarteritis. Okay, so since these terms are there, you might have a tendency to think that it is the aorta that is most commonly involved. Answer is no. I'll just show you a picture from a table from Harrison on the vessel involvement in the Takayasu arteritis. So you see here, the most common vessel that is involved is your subclavian artery. Okay, is your subclavian artery. Okay, it is not your aortic artery, aorta. But remember one fact, the percentage of aortic involvement in Takayasu is definitely more than what giant cell arteritis. Okay, so let's see what are the other vessels involved. Common carotid, abdominal aorta, renal vessels, aortic arch. So you see here the aortic arch or root is involved in around 35%. Okay, so giant cell arteritis was again a lower percentage, around 25%. Vertebral artery, celiac artery, superior mesenteric, iliac, pulmonary, coronary. So coronary and all is very rare to be involved in case of a Takayasu arteritis. So the manifestation of Takayasu arteritis will depend on what is the vessel that is involved. You can have a subclavian involvement, that is the most common, resulting in a claudication. So this is one point that you have got to look in the clinical scenario in an exam. Okay, so since the subclavian is more commonly affected, you can have an arm claudication. The common carotid, so because of the common carotid involvement, you can have strokes as well. Now this is very important because giant cell arteritis, I told you, is less likely to present with strokes, but Takayasu arteritis is very well known to produce strokes. Okay, and the abdominal aorta involvement can produce abdominal pain, nausea, vomiting. Renal involvement can produce hypertension and renal failure. Aortic involvement can produce aortic regurgitation. Okay, again very very important. Then you can have vertebral artery involvement, celiac axis involvement, superior mesenteric artery involvement. So when the superior mesenteric artery is involved, it can produce ischemia of the bowel and presentation very similar to acute abdomen. But again, the percentage superior mesenteric artery involvement is more common with respect to another vasculitis that we are going to learn, that is your polyarteritis nodosa. Okay, so these are the frequency of the clinical features that you get in case of the the Takayasu arteritis. So always keep this in mind because you might get a clinical scenario. So let's have a look at the ACR criteria for Takayasu arteritis. So remember, first point, very very important, you are suspecting this Takayasu in a younger age group, that is of less than 40 years. Okay, you can have presentation in the 20s, 30s. Limb claudication, and remember that Takayasu arteritis, it has another name along with the previous names of aortic arch syndrome, non-specific aortoarteritis. It's also referred to as the pulseless disease, because when there is involvement of your large vessels, sometimes you might see that you might not get pulse in one region. because we had a patient with in our ward admitted with a stroke. Okay, so for that particular patient on the left upper limb, the brachial artery, radial artery, none of the vessels were, the pulsations were palpable. So you can have absent pulses. Okay, so decreased brachial artery pulse, unequal blood pressure. So you can get an anisospygmia, because sometimes you might get pulse, but there will be a asymmetry in the pulse volume. Okay, because if you check the pulse, certain individuals it might be totally absent, pulseless. Certain individuals pulse will definitely be there, but always make sure that bilaterally you should examine. Which is why when you have a patient with a young stroke, it is always advised that don't just look the pulse in one radial artery. You would always look the pulses both sides and compare the volume also, because young stroke could be because of a vasculitis, and in Takayasu arteritis you might have a difference in the volume of pulse. You might see that on one side the pulse volume is very good, on the other side you do not have a adequate pulse volume. So that is again giving a clue that there is some problems with the vessel. Subclavian or aortic bruit, again the subclavian and aortic bruit is more common in Takayasu compared to your giant cell arteritis. And how do you confirm your Takayasu arteritis? See, since this is a large vessel arteritis which is predominantly affecting your subclavian, the common carotids, your aortic, your renal vessels. So because of which you cannot do biopsy as easily as in giant cell arteritis. Because giant cell arteritis, you can go for a biopsy of the superficial temporal artery. But what about Takayasu? You cannot just biopsy your aorta. So it's mostly a diagnosis based on the clinical presentation plus your angiographic abnormalities. So when you do an angiogram, suppose you are doing a CT angiogram for the patient, you will be able to demonstrate the narrowing of the large vessels. The large vessels will be significantly stenotic at the region of maybe subclavian, carotids or aorta. You will obviously notice all these narrowing. Okay, so evidence of narrowing of the aorta and its branches or the large limb arteries, that is the importance of angiography in case of a Takayasu arteritis. Okay, so let's just discuss the treatment of Takayasu arteritis. See, treatment of Takayasu arteritis, you can go for steroids. Okay, steroids can be used as in case of your giant cell arteritis. You can start the patient on oral steroids and subsequently taper the dose. Maybe in life-threatening complications, you can think of a methylprednisolone pulse. Okay, so steroids are often used. And I told you tocilizumab is used in giant cell arteritis. It has been tried in cases of Takayasu arteritis as well, and the results have been reasonably good. So we might see tocilizumab being used more and more in Takayasu arteritis, because let me tell you, this is not a good disease to have. Because see, the time I was doing my MD medicine, I did my MD medicine in Government Medical College, Calicut, Kerala. So there, the time I was first year, we had a female of around say 46 years. She was admitted with a stroke. Okay, so I was first year then, and at that time we had evaluated, and in the angio itself it was shown that she had a occlusive disease involving her carotids, as well as in the aorta also. We did a CT aortogram also. So in there also there was narrowing. And see, what happened was that we managed her with steroids, but later, even despite being on steroids, she developed recurrent episodes again, because the actual problem is persisting. No, when you're giving steroids, to some extent it can decrease the inflammation and maybe some symptom relief, but she had a significant narrowing, so that she developed recurrent episodes. So from my first year to final year, at least she has had 3 or 4 hospital admissions with stroke. Okay, and it is not a good sight to see, because you cannot offer much. Yes, you can go for an angioplasty, but the problem is that in her case there were significant stenosis at multiple vessels. So if it was a single vessel involvement, you could go for an angioplasty. Okay, so that is another treatment option. You can go for angioplasty, but the problem is she had multiple large vessel stenosis, which made things all the more difficult. So I just wanted to convey a message to you that this is not a good disease to have, the Takayasu arteritis, and the treatment response is not that great. Okay, So that's it about the Takayasu arthritis. So now let's just compare. This is a comparison table in Kelly's textbook between giant cell arthritis and Takayasu arthritis. So the first 2 points you see, the female to male ratio is very much striking in Takayasu, almost to the tune of 80:1. Okay, so very common in females less than 40 years, and you see the average age of onset 25 years. And visual loss, it is more common with your giant cell arthritis, and you see the extent of involvement of aorta. See, though we see here 100%, it is mainly you have learned that in the Harrison table that aortic arch and its branches around 35%. So in Takayasu arthritis, though obvious manifestations with aortic involvement is again around the tune of 35-40%, but more often than not you will have at least some subclinical evidence of an aortic involvement. If you do suppose you have a patient with Takayasu arthritis who has had a subclavian stenosis, and maybe the patient, once the patient expires, you do an autopsy, you might find that even your aorta is also showing the features of large vessel inflammation. Okay, so that is again a point to be kept in mind. So both of them are granulomatous arthritis. So previously the giant cell arthritis was given a name, granulomatous arthritis, but now remember that both of these entities have granulomatous arthritis. Remember, pulmonary involvement is almost never seen in a case of giant cell arthritis, but it can be seen in around 10 to 30% cases of Takayasu arthritis. Renal hypertension also is common in Takayasu arthritis, whereas it is very rare in case of a giant cell arthritis. Claudication symptoms, remember a large vessel vasculitis which presents with claudication symptoms is most likely going to be a Takayasu arthritis. And Takayasu is more common in Asian. Let me tell you, in the Indian population also this is again very common. We call it non-specific iotoarthritis. There is also a viewpoint that this Takayasu arthritis could be in fact a tuberculous iotoarthritis. That is tuberculosis triggering a iotoarthritis. So there is a bit of debate on that, whether this is actually triggered by an infection, especially with the higher incidence of the iotoarthritis in the Asian population. So whether it is related to tuberculosis as an infection, because it is more common in our areas. And both of them are steroid responsive, but I would say that giant cell arthritis has a better steroid responsiveness. Bruit is mostly present in case of Takayasu, and surgical intervention may be required in case of Takayasu because of the large vessel stenosis that can happen in Takayasu. Okay, so that's it about the large vessel vasculitis. We have covered both the giant cell arthritis as well as Takayasu arthritis. Now we come to polyarthritis nodosa. Polyarthritis nodosa, which is a medium vessel vasculitis. Okay, we are going to discuss the medium vessel vasculitis, PAN. Okay, so polyarthritis nodosa is a medium vessel vasculitis. That is the first point that you have got to know. It is a medium vessel vasculitis. Now this vasculitis PAN, okay, so some important points that you have got to know is that one is the age group of presentation is at around 50 to 60 years. Age group of presentation of PAN is 50 to 60 years. So these age groups, you have got to keep in mind because you get clinical scenarios based on that. And then, there are certain no's that you have got to remember. In polyarthritis nodosa, there is no granuloma formation. So remember, in your giant cell arthritis as well as Takayasu, they were granulomatous arthritis. So here you will not see any granulomas. And here you will not see any involvement of the pulmonary vessels. So no pulmonary vessel involvement in case of your polyarthritis nodosa. But remember, bronchial vessels may be involved. Okay, so that is one point you have got to know. There is no pulmonary vessel involvement, but bronchial vessel may be involved. Okay, so there is no pulmonary vessel involvement in case of polyarthritis nodosa, and there is no glomerulonephritis in case of PAN. Okay, because it is a medium vessel vasculitis, it can affect the renal artery. Okay, it can affect the renal artery. So I am not saying that it will never affect the kidney. What I am saying is that it will not affect the glomerulus. So there is no glomerulonephritis, but there can be a renal artery involvement. Okay. So this point is very important because you have to compare this PAN with other disorders like microscopic polyangiitis or the microscopic PAN. So there these points will have its own importance. And this is not having any ANCA association, not having any association with any anti-neutrophil cytoplasmic antibodies. So you've got to keep in mind these points about polyarteritis nodosa. And polyarteritis nodosa, I told you, presents with medium vessel vasculitis. So what are the manifestations of a polyarteritis nodosa? I told you it is 50 to 60 years of age group. So the clinical presentation of polyarteritis nodosa will depend on the what are the vessels that are involved. Okay, so let's have this the organ system involvement in case of PAN. So it depends on the vessels that are involved. So in renal, I told you renal artery can be involved, so you can have a renal failure and hypertension. Musculoskeletal involvement is very, very important in PAN because sometimes the clinical scenario given to you, PAN might present with an arthritis, arthralgia, myalgia. Okay, so remember it is almost 64% cases of PAN can present with such musculoskeletal symptoms. And another important clinical scenario they might ask is that among the vasculitis, this is the vasculitis that has highest propensity to develop a mononeuritis multiplex. Again, an important question. So the patient might be having a past history of wrist drop, now presents with a left foot drop. Okay, so mononeuritis multiplex is very common with your PAN. Then you can have GI tract involvement, especially when there is a superior mesenteric vessel involvement. Okay, so that can cause a acute abdomen. It can result in bowel infarction as well as perforation when there is a mesenteric ischemia. Okay. Now cutaneous involvement is also common in case of PAN. You can have rashes, you can have purpura, nodules, livido reticularis, Raynaud's phenomenon. All these are common with polyarteritis nodosa. Cardiac involvement can be there, congestive heart failure, myocardial infarction and pericarditis. Genitourinary infection, very, very important. Testicular, ovarian and ependymal pain. Most important is that they might give you a clinical scenario of a testicular torsion like clinical picture they might give you for the exams, and they may give you some clue of PAN as well. Okay, so this is again an important clinical presentation, and it can affect the CNS as well, resulting in strokes, seizures. Okay, so these are again presentations of the polyarteritis nodosa. Okay, and polyarteritis nodosa, always remember one more point, that it is having an association with hepatitis B infection. That is almost, you can say that 30% patients, okay, 30% of the polyarteritis nodosa patients will be having a hepatitis B infection. Okay, so probably the infectious trigger in case of, it's that one of the infectious triggers or the antigens that is triggering the vasculitis in a PAN could be a hepatitis B infection. And remember that PAN is also having an association with hairy cell leukemia. Okay, that point also keep in mind, you might get a question. And a very, very important finding is that when you want to diagnose PAN, an important investigation will be your angiogram. And in the angiogram, the PAN will actually show the finding of microaneurysms. I'll just show you a picture of that. Okay, so this is a renal artery involvement in case of a polyarteritis nodosa, PAN. Okay, so PAN, I told you the age group is 50 to 60 years, but I told you this can even present in a younger age group. But remember, this is a rare presentation. The common age group is 50 to 60. Just because this image from Harrison shows that this is about a 19-year-old. So I'm just telling that there can be atypicalities also. Okay, so here you can see the various microaneurysms, multiple microaneurysms. Can you see them? Okay, throughout the renal vasculature you are seeing the aneurysms. Okay, and see how this patient presented. Headache and severe hypertension. Okay, it is because of the renal artery involvement the patient had hypertension. You remember I told you The presentation can be with renal failure and hypertension. So it is important to pick up the PAN in clinical scenarios. So you might be given a patient, a clinical scenario of a 55-year-old male with a hepatitis B infection and a recently detected hypertension, and the angiogram finding may be shown, and you might be asked the diagnosis. Okay. And this one is a polyarteritis nodosa with a cutaneous manifestation. You can see this is a livedo reticularis and subsequent ulceration has occurred in the livedo reticularis. Okay. So just the ACR criteria for the polyarteritis nodosa, you can have weight loss. So systemic features are common. You see it is a significant weight loss that occurs in PAN, as much as more than 4 kg. Livedo reticularis, testicular pain and tenderness, musculoskeletal manifestations, mononeuritis multiplex. You can have hypertension, especially the diastolic BP will be increased. Even systolic BP can be increased, but since it is a vasculitis, more likely the peripheral resistance is going to be affected, so the diastolic hypertension is likely. You can have renal failure because of the renal artery involvement. Hepatitis B infection may be associated. Angiographic abnormalities, that is multiple microaneurysms may be there. And if you do a biopsy, you can see it is flooded with neutrophils, which are the inflammatory cells in your PAN. Okay. So this is about the clinical features, okay, and the investigation in case of polyarteritis nodosa. How will you treat PAN? So treatment of PAN is again, you can resort to steroids, okay, but most often steroids alone won't do the trick. You will have to go for a cyclophosphamide also. So steroids plus cyclophosphamide may be required in polyarteritis nodosa. So there, these are the important features of polyarteritis nodosa. Regarding the second medium vessel vasculitis, Kawasaki disease, that will be discussed in the pediatrics modules of there you have because the presentation of Kawasaki disease is actually in the younger age group. Okay, so it will be discussed along with pediatrics. All right. So after the medium vessel vasculitis, we are moving on to the small vessel vasculitis. So small vessel vasculitis, as I have explained before, is divided into two types. You have the ANCA associated vasculitis, okay, and the immune complex vasculitis, immune complex mediated vasculitis. So that is how you will divide the small vessel vasculitis. And first we will discuss the ANCA associated vasculitis and then move on to the immune complex vasculitis. Okay. So first heading, ANCA associated vasculitis. So ANCA, I told you it stands for anti-neutrophil cytoplasmic antibody. I told you there are two types of ANCA, that is you have your P ANCA and C ANCA. So P ANCA is the perinuclear pattern of staining in immunofluorescence, and C ANCA is the cytoplasmic pattern in immunofluorescence. And this P ANCA is directed against myeloperoxidase, okay, and this myeloperoxidase is present in the azurophilic granules of monocytes and neutrophils. Okay. All right. And this C ANCA is directed against proteinase 3. Okay, it is directed against proteinase 3, and this proteinase 3 is present in the neutrophil granules. Okay, the granulocytes of the neutrophils. Granules of neutrophils. Okay. All right. So these are the two types of ANCA antibodies that you will have. And what are the important ANCA associated vasculitis? I told you there are three main ANCA associated vasculitis. You have the GPA, which is your vaginous granulomatosis. You have the microscopic polyangiitis, microscopic polyangiitis, also referred to as microscopic pan, and the third one is the EGPA or your Church-Strauss vasculitis. So these are the three important types. There is also another subtype which is not very important for your exam, but just know that it is also a subtype of the ANCA associated vasculitis, that is called a renal limited vasculitis. Okay, renal limited vasculitis. Okay, so these are the four types of ANCA associated vasculitis. Okay, now see, I'll just show you a table, the various antibodies, that is the ANCA antibodies. Anti-PR3 is your anti-proteinase 3 and anti-MPO. So out of these four ANCA associated vasculitis, please understand that certain antibodies are found more in frequency in certain disorders. Okay, for example, if you take GPA, which is your vaginous granulomatosis, around 80 to 90% will be having anti-PR3, that is antibodies against the proteinase 3, which is your C-ANCA. But see, around 10% cases may also have anti-myeloperoxidase antibody. Okay, but when you say predominantly what is the ANCA antibody in a vaginous granulomatosis, your answer is going to be a C-ANCA or a anti-PR3. Okay, so let's see the other disorders also similarly, because in your exam you've got to know which are the P-ANCA related vasculitis and which are the C-ANCA. So when it comes to microscopic polyangiitis, see, almost 60 to 70% will be having anti-myeloperoxidase, okay, which is your P-ANCA. So though around 10 to 20% are having your anti-PR3, it is predominantly a P-ANCA associated vasculitis. Renal limited vasculitis, the entity renal limited vasculitis, you can see that almost 64% is your anti-MPO. Okay, and the final one, that is your Church-Strauss vasculitis or the EGPA, you can see that almost 50% is anti-myeloperoxidase. Okay, so out of the ANCA associated vasculitis that we are learning, 3 of them are predominantly showing an anti-MPO positivity, and whereas your vaginous granulomatosis is showing a anti-PR3 positivity. You have got to get this in your head, because in the exam, when a clinical scenario comes, these vasculitis will be having certain overlapping clinical features. So one of the hints in the exam question might be a ANCA antibody. So depending on whether it is anti-MPO or anti-PR3, you have got to make a clinical decision there. Okay, all right. And remember, when we divide these into two vasculitis, the ANCA associated vasculitis of the MPO and your PR3, remember, in some part of the, in a small subpopulation of the disease, you see here, especially in your Church-Strauss vasculitis, you can see almost 35 to 50%, which is a big percentage, may have a negative ANCA. Okay, so that is also possible, and you have got to keep that in mind. Okay, so you have got that. All right. So next we will move on to the individual subheadings of the in the small vessel vasculitis, that is the group of ANCA associated vasculitis. First disorder that we are going to discuss will be a GPA, granulomatosis with polyangiitis. And let me tell you one more point before I go into the discussion. See, all these vasculitis will be having in common a feature, that is, they are all necrotizing vasculitis. They are all necrotizing vasculitis. Okay, so also keep that in mind. So coming to GPA, or what do you call that? Vaginous granulomatosis. Okay, vaginous granulomatosis. Okay, so it is necrotizing granulomatous vasculitis. Okay, GPA is a necrotizing as well as a granulomatous vasculitis. Necrotizing granulomatous vasculitis. And the age of presentation is somewhat around the 40 to 50 age group. Okay, so age of presentation is around 40 to 50 years of age. Okay, in vaginous granulomatosis, almost equal incidence between males and females. Okay, almost males, almost equal to females. Now, see, I told you the basic problem is it is necrotizing and it is granulomatous vasculitis. And this vasculitis is affecting multiple organs and organ systems. But the brunt of the attack in this vasculitis falls to three predominant areas. One is your upper respiratory tract. That is the one which is most often involved. Then you can have involvement of your lower respiratory tract as well as your kidneys. So these are the three predominant areas where you have the brunt of the attack in case of your vaginous granulomatosis. Now if you are asked among all these what is the most common site of involvement, it's the upper respiratory tract. Important. But along with this, other organs also can be involved. You can have involvement of your eyes, you can have involvement of skin, you can have involvement of peripheral nervous system, that is you can have a neuropathy associated, and maybe rare cases can have a central nervous system involvement as well. Okay. Alright, so these are the various organ systems affected in case of a vaginous granulomatosis. And whatever be the site involved, the pathology is predominantly a vasculitis. Okay, so it is related to your ANCA, the anti-neutrophil cytoplasmic antibodies, which is inciting release of certain cytokines and subsequent damage to the endothelial cells, as well as release of certain reactive oxygen species, which is very responsible for inciting the vasculitis in this individual. And along with this vasculitis, you can also have a granuloma formation. Okay, this is also very important. Granuloma formation, in which you have a central area of necrosis, and along with that you have the epithelioid cells, neutrophils, T cells, monocytes, giant cells, fibrocytes. Okay, so you will also have the granuloma formation. Okay, so this is just the patient with a vaginous granulomatosis, a biopsy description. So this is just a histopathology specimen, and you can see that there are sheets of lymphocytes and areas of necrosis. Okay, so you can appreciate the granulomas, you can appreciate plenty of inflammatory infiltrates happening here. Okay, so all in all, it is a necrotizing granulomas. So granulomas with central areas of necrosis, as you have seen in this particular picture. Okay, all right. Now see, now let's come to the individual affection. Okay, I told you three areas are predominantly involved. So let's first see how the respiratory tract is involved. See, when the respiratory tract is involved, the upper respiratory tract involvement, okay, upper respiratory tract, this can produce variety of manifestations. Okay, you can have sinusitis. Okay, you can have sinusitis associated with the vaginous. You can have serous otitis media. You can have involvement of your nasal septum. Okay, so nasal septal involvement, sometimes even leading on to perforations or sometimes even deformities of your nose. A characteristic deformity is often referred to as the saddle nose deformity. I will show you the picture in a while. Saddle nose deformity. Okay, so sinusitis, serous otitis media, nasal septal involvement, these are the predominant upper respiratory involvements. You can also have sometimes subglottic stenosis also. Subglottic stenosis. Okay, and one point you have got to note is that it has been found that when there is a chronic nasal carriage of staphylococcus, in those individuals having a chronic nasal carriage of staphylococcus, there is a high incidence of the recurrent episodes of vaginous granulomatosis. That is, see, this is a chronic disease process, and it was found that in individuals who are harboring staphylococcus in the nasal cavities, the chance of recurrent episodes with the upper respiratory tract involvement or even the other lower respiratory tract involvement is more in such individuals. So just keep that as a point in mind. So that's it about the upper respiratory tract involvement. Then coming to the lower respiratory tract. Okay, see, lower respiratory tract involvement, it can be in the form of different manifestations can be there. You can have a manifestation of pulmonary nodules. Either the patient may have pulmonary nodules or pulmonary cavities or pulmonary infiltrates or even a diffuse alveolar hemorrhage. Okay, diffuse alveolar hemorrhage. So all these are pulmonary manifestations. So patients may have cough, dyspnea, and if there is a pulmonary alveolar hemorrhage, may also have hemoptysis. Okay, hemoptysis. So all these manifestations may be there because of the lower respiratory tract involvement. Okay, so most commonly you have the upper respiratory tract, then you have the lower respiratory tract, and then you have the kidney involvement. Okay, so kidney involvement, you can have a glomerulonephritis. Okay, you can have a glomerulonephritis, and sometimes it may be initially in the initial presentation may be in the form of just a proteinuria, hematuria. Okay, patient might present with a hematuria. On evaluation, you find that patient is also having a proteinuria, maybe some RBC cast. But subsequently, the patient can go for a rapidly progressive glomerulonephritis, RPGN, and subsequently there can be a renal failure also. Okay, so renal involvement, if it is not attended to earlier, can result in renal failure. So these are the most important manifestations of vaginous granulomatosis, but at the same time, it can involve the eyes to form maybe a conjunctivitis may be there. You can have episcleritis as a manifestation, maybe scleritis. Okay, and in the skin you can have purpura. You can have in the peripheral nervous system a peripheral neuropathy. So all these manifestations may be there in case of your vaginous granulomatosis. So it's important to understand the magnitude of symptoms that can happen. So always remember, as I talked with any multi-system disease in this rheumatology chapter, patients can have varying degrees of severity. It need not be that any individual would have all these manifestations. So the severity can be varied depending upon the extent of involvement. And also remember that along with all these symptoms, you can also have systemic symptoms like fatigue, malaise, weight loss, arthralgia. So all these symptoms also may be there. Now just to have a look at some of the images, this is a table in Harrison showing the frequency of involvement. You already know that it is the upper respiratory tract that is most commonly involved. Sinusitis, nasal disease, otitis media, hearing loss, subglottic stenosis. Okay. Then in kidney you can have glomerulonephritis, lung, pulmonary infiltrates, nodules, hemoptysis, pleuritis. All these are major manifestations. Just a revision of what we have learned. And tell me, what is this? You guys tell me, what is this deformity? Okay, this deformity is classically referred to as a saddle nose deformity. So if you are asked a clinical scenario in your exam of a possible vasculitis with this deformity, no doubt this is going to be what? Vaginous granulomatosis. Very, very important. Okay. And this is just another CT picture of a patient who presented with a vaginous granulomatosis. You can see bilateral cavities. You can see cavitating lesions which are located bilaterally. Okay. Alright, because you might be getting such a similar image in the exam also. So in some individuals it may be in the form of a hemorrhage. You can see in this patient there is diffuse alveolar hemorrhage. So just by looking at a chest X-ray, it is not possible to differentiate between a hemorrhage or a infiltrate. But still, this case turned out to be a diffuse alveolar hemorrhage. Okay, the patient actually had hemoptysis also. Okay, and this is another patient of who had vaginous granulomatosis, and you can obviously see here that the orbit on the right side, so much of inflammatory tissue extending from the sinus, okay, and filling the orbital space. Okay, the patient actually had a dreaded visual loss also, okay, and severe proptosis, which you can appreciate in this CT itself. And here another CT image, you can see that the sinus on the left side, it is very much sclerotic, and it is very much small in size also, which means there has been a significant destruction that has happened to the region of the maxillary sinus. Okay, so you can anticipate the extent of involvement it causes on the upper respiratory tract. I already told you the brunt of the attack initially might go to the upper respiratory tract. Okay, all right. So these are the important features of vaginous granulomatosis. Okay, so the clinical picture would actually help you in the diagnosis, and you can go for a CNK as well. Okay, CNK estimation. But remember, the positivity of CNK, as you have learned in this, is around 80 to 90%. So you will have around 10 to 20% who are negative for CNK as well. Okay. Now, treatment of the vaginous granulomatosis we will discuss towards the end. Okay. So what we are going to do is we are first going to discuss the ANCA associated vasculitis, and together we will just discuss the treatment of that. Okay. Alright, so I hope vaginous is very clear for you, a very important clinical question for your exam. Alright, and just one point you can know here, that if you go for a biopsy, okay, in case of vaginous granulomatosis, see, commonly you might go for a renal biopsy, correct, no? You might go for a renal biopsy, or if he has presented with some nasal mass, you might go for a biopsy from there. But sometimes when you go for a renal biopsy, you might not get the actual diagnosis, okay. You might get, but the point I want to tell you is that it is the lung biopsy in case of vaginous granulomatosis that has the highest diagnostic yield, okay, highest diagnostic yield. This by no means I am saying that, in every patient who has a vaginous granulomatosis, you should do a lung biopsy, but MCQ purpose you should know that this is the lung biopsy specimen is the one which has the highest diagnostic yield, where you are able to better demonstrate your granulomas, the necrotizing granulomas in the vasculitis, vaginous vasculitis. Okay, so this is clear. So next let's move to the second entity. The second entity is on microscopic polyangiitis. Microscopic polyangiitis. So microscopic polyangiitis, age of presentation is almost similar to that of vaginous granulomatosis, but around 45 to 55 years. So this will be slightly more in males compared to females, okay, microscopic polyangiitis. And see, I told you the common feature that bridges all the ANCA associated vasculitis is the necrotizing vasculitis. So obviously here also you will be having necrotizing vasculitis, but the problem is that here the necrotizing vasculitis in microscopic polyangiitis will be without granulomas. So you will have a non-granulomatous necrotizing vasculitis. This is very important, because when you discuss the Church-Strauss also, I will be telling you that there are granulomas in the Church-Strauss disease, but here no granulomas. So keep that in mind, a possible question. Now coming to the clinical picture of a microscopic polyangiitis, clinical features. So the dominant clinical picture in a microscopic polyangiitis will be with a renal involvement, okay, renal involvement. So patient would be having a rapidly progressive glomerulonephritis. So initially patient might have some hematuria, so proteinuria will be there, cast will be there, but again it can progress to RPGN and a severe renal failure might be there. So that is very important, renal failure, a dominant manifestation. You can also have cutaneous involvement, which is again a dominant manifestation of microscopic polyangiitis. And here again in microscopic polyangiitis you can have all these purpuric skin lesions, okay, purpuric skin lesions. And lung involvement also can occur in case of your microscopic pan, but unlike vaginous where you have infiltrates, nodules, cavities, the usual presentation will be that of a diffuse alveolar hemorrhage. Okay, the usual presentation will be that of a diffuse alveolar hemorrhage. Okay, so tell me what will the patient present with? He will be having this dyspnea, hemoptysis, cough. These will be the manifestations. So always keep that in mind. So just remember that in any vasculitis with a pulmonary involvement is not limited to a single disorder. So you have multiple vasculitic disorders presenting to you with a diffuse alveolar hemorrhage, which is why it is always important to see the question as a whole. Okay, because long stem questions when it comes for the exam, sometimes you might just see this diffuse alveolar hemorrhage and probably have read, okay, vaginous has diffuse alveolar hemorrhage. So you might jump for vaginous, it might be a case of a microscopic polyangiitis or maybe another disorder like a Goodpasture syndrome. So please do read the question well. What is the examiner trying to ask you? Which is why when you learn this chapter on vasculitis, you've got to understand a disease as a whole. How does it present? Okay, because if you have a patient with a, say, a pulmonary hemorrhage, who is also having an upper respiratory involvement and maybe some saddle deformity of the nose, then it is giving you almost a conclusion that this could be vagus. Okay, so it is about interpreting the individual clinical findings together. That is the beauty of clinical medicine. Just because you spot out one sign or maybe you elicit a particular history might not always give you a clinched diagnosis, because always clinical medicine is not about spotter diagnosis. Okay, spotters you have in your exam where you have a spotter station and you're asked to diagnose. But in real life practice, don't think that always it is a spotter type station. So you will have to make decisions, and for that you will have to have a holistic approach to the patient and his problems and then work up accordingly. Okay, so these are the presentations of your microscopic polyangiitis, and I have already told you microscopic polyangiitis you have a P-ANCA positivity. Okay, P-ANCA positivity, and always remember one point, that in case of microscopic polyangiitis, which is also known as microscopic PAN, remember the presentation is very different from a PAN, because in PAN the renal arteries were involved, the glomerulus was not involved. Okay, so you will not get a glomerulonephritis in PAN. What you will get is a renal artery involvement and subsequently maybe a hypertension. Okay, so glomerular involvement means the smaller vessel involvement. So it is the microscopic PAN that is a small vessel vasculitis. So you have got to understand that. Okay, all right. So, and also remember, PAN, does it have any ANCA association? Remember, it is not an ANCA associated vasculitis, but microscopic PAN is an ANCA associated vasculitis. Okay, all right, very clear to you? All right. So next let us move, treatment part we'll again see together. Okay, now next we'll move to the third disorder, that is your eosinophilic granulomatosis with polyangiitis, that is your Churg-Strauss syndrome. Churg-Strauss syndrome. So the current term is EGPA, but there is always a good chance that in the exam you might get with the Churg-Strauss itself. Okay. So what is this disorder, eosinophilic granulomatosis with polyangiitis? See, this is a disorder, again, let me first start off by saying that this is a necrotizing vasculitis, as is common to all ANCA associated vasculitis. But this necrotizing vasculitis, it is associated with granulomas. Okay, so this has granulomas. Remember, microscopic PAN, no granulomas. So Churg-Strauss syndrome is slightly more common in females than males. Age group of presentation around 40 to 50 years. Average age they say is around 48 years. So what about this Churg-Strauss syndrome? So to sum up, I'll say that if I'm asked what is this Churg-Strauss syndrome, first of all, this is a small vessel vasculitis, which is a necrotizing granulomatous vasculitis characterized by, okay, so what are the important characters? One is asthma. Okay, one is asthma. Second is eosinophilia. Is it limited to the tissues or is it limited to the blood? Remember, both tissue and blood eosinophilia. Tissue and blood eosinophilia. And you will have granulomas, but remember it is extravascular granulomas. Extravascular granulomas. So in your vaginous you have both intravascular and extravascular granulomas. Churg-Strauss extravascular granulomas. Microscopic PAN, no granuloma. Okay, and along with these you will have vasculitis affecting multiple organ systems. Okay, vasculitis affecting multiple organ systems. Okay, so this is what is your Churg-Strauss vasculitis. Okay, so when you take the clinical picture into account, see, if you are asked what is the dominant clinical picture, remember I told you microscopic PAN, the renal involvement will usually dominate the picture. Here it is the asthma. Okay, so you will have asthma with pulmonary infiltrates. Okay, so asthma with pulmonary infiltrates, again a dominant finding. And you will have a associated eosinophilia also, which means the eosinophil count will be more than 1000 per microliter. Okay, so the eosinophil count will be more than 1000. Remember, there is tissue eosinophilia also in addition to the blood eosinophilia. So you will get recurrent respiratory presentations, that is your asthmatic presentations. So always don't think that anybody and everybody who's having a asthmatic episode, okay, I say asthmatic episode, somebody might present with wheezing, do not always think that it is bronchial asthma, because in the hint, the exam question, you might get a question of say around a 45-year-old female who presents to you with recurrent episodes of bronchial asthma, which is not well controlled. Okay, she's having recurrent bronchial asthma episodes, and at present presentation you're finding that the eosinophil count is high, and you might be given an image also showing that maybe on examination there is a purpuric, okay, the vasculitic rashes or purpura in the lower limb, just like this one. Okay, you can have a purpuric rash in the lower limb. So you might be asked what is a diagnosis. So it is up to you to correlate this asthma, the eosinophilia and the vasculitic skin lesions, and then come to a diagnosis of Churg-Strauss syndrome. Okay, alright. So this is very, very important. Asthma with pulmonary infiltrates, eosinophil more than 1000. Can it affect the kidney? Yes, renal involvement can be there. There can be a rapidly progressive glomerulonephritis resulting in a renal failure. And also keep in mind an interesting affection, that is the affection of your myocardium. Just before myocardium, the vasculitic skin rashes also. You can get vasculitis skin rashes and purpura. Okay. And finally, you can have a myocardial involvement. So I am putting this in red for a reason, that the myocardial involvement in Churg-Strauss is the most common cause of mortality. Okay, most common cause of mortality. Morbidity definitely is due to other, the asthmatic episodes, okay, the renal involvement, but mostly the mortality in the Churg-Strauss vasculitis is because of myocardial involvement. Okay, so that is also very, very important. Okay, so we have seen the important vasculitis, the small vessel vasculitis, which are related to ANCA. I'll just show you one table where we are trying to compare the three important, that is your microscopic polyangiitis, granulomatosis polyangiitis and PAN. Okay, not the eosinophilic granulomatosis. This is just a table because I don't want you to get confused between the clinical features. So it's better that you form a table and so that you study it now and for all. Okay. So this is just a subdivision into PAN, MPA and GPA. Remember, PAN is a medium vessel vasculitis. It is not an ANCA associated vasculitis, but you should know the comparison between these entities, because sometimes in the exam you might get confused. Because Churg-Strauss I am not discussing here because you are unlikely to confuse Churg-Strauss. Because Churg-Strauss, the dominant picture is the asthmatic episodes, and it is very unlikely that any other vasculitis would present with such asthmatic episodes. Okay, so let's see the differences. The kidney involvement, you already know that the renal vasculitis with a microaneurysm formation is seen in what? Your PAN. Because PAN is the medium vessel vasculitis. So renal vasculitis, renal infarcts, microaneurysms, all are related with PAN. Then what about this MPGN, your microscopic polyangiitis and GPA? See, the kidney may be involved, glomerulonephritis is there, but remember, there is no renal artery vasculitis. Okay, that is why you do not have a involvement here. But what about RPGN? See, glomerulonephritis is again small vessels being involved, which is why your MPA and granulomatosis polyangiitis will be having, whereas PAN will not be having. What about the lung involvement? See, alveolar hemorrhage presentations can occur in both vaginous as well as your microscopic polyangiitis. Very important. Hepatitis B infection, see, it can occur in PAN. So it is not 10%, you can correct it to 30%, that is the current latest data. And you will not be having a hepatitis B association in the other disorders. The P ANCA, what about P ANCA? See, it is the microscopic polyangiitis in which you get a P ANCA positivity. What about GPA? It is mostly C ANCA, but C ANCA in all cases? No, almost in around 80% cases. So 10 to 20% cases you might have a P ANCA in a GPA also. Then microaneurysms in angiogram, I have already showed you the image also I have showed you, that should be there in your mind. I hope while I teach you this, that image is there in your mind. So that is there in your PAN. And histology, necrotizing vasculitis. See, PAN also has a necrotizing vasculitis. See, that is one common feature PAN has with other ANCA associated vasculitis. It is a necrotizing vasculitis. Okay. But remember that in case of PAN, it's a necrotizing vasculitis which is not associated with ANCA. Okay. So MPA, again necrotizing vasculitis without granuloma, and GPA is a granulomatous necrotizing vasculitis. And relapses are more common in case of your MPA as well as GPA. Okay. So it is in those two conditions that you have relapses. So always keep it in a table format, because it is likely that you might confuse in exams. Okay. So examiner might be trying to figure out or confuse you by asking you some question regarding which is an ANCA associated vasculitis. They may have PAN in the options. Okay, so you might think about microscopic PAN, and then you might think that okay, that also has ANCA, but no. Remember, PAN is a medium vessel vasculitis, and medium vessel vasculitis is not an ANCA associated vasculitis. Okay, so keep that in mind. Okay, so these are the important differences. So having seen everything, we will now come to the treatment aspects. Treatment of ANCA associated vasculitis. So I'm going to discuss the ANCA associated vasculitis treatment in the form of a flow chart. Okay, so a flow chart that is given in Kelly's textbook of rheumatology. It's a simple flow chart. The basic point that you have got to know in ANCA associated vasculitis is that most often you will treat with steroids. Okay, so you will start treatment with steroids, but if the disease is severe, you will have to add cyclophosphamide, steroids plus cyclophosphamide, and sometimes you will have to add other agents like rituximab, or sometimes you might have to add steroid sparing agents. And also one drug that you should know is mepolizumab. So mepolizumab is a monoclonal antibody against IL-5, and you tell me in which of the disorders that we learned in this group of ANCA associated vasculitis will mepolizumab be useful. Now to understand that, you have got to, there is a line in pathology Robbins textbook. If you are able to recollect that, you will be able to say it, that this interleukin 5 is the most potent eosinophil activating cytokine. Okay. Now I am sure that you got the answer. This is the most potent eosinophil activating cytokine. So this is an antibody targeting IL-5, and this can be used for your Churg-Strauss vasculitis. Now let's come to the treatment aspects. Okay, what the points I said were general points, but again it varies based on the disease and the severity. So let's see this. Okay, this is active AAV. AAV stands for ANCA associated vasculitis. ANCA associated vasculitis. So let's see them. You have your EGPA, which is your eosinophilic granulomatosis with polyangiitis. So EGPA is the Churg-Strauss. So if the Churg-Strauss vasculitis is without poor prognostic factors, so recurrent asthmatic episodes, severe vasculitic ulcers, renal involvement, these are poor prognostic factors. So if there are milder attacks of asthma, then you can go for steroids. Subsequently, you can taper the doses of steroids, and then you can, if needed, you may go for a steroid sparing agent like azathioprine. But in due course, suppose if you have started steroids, if the patient is not responding or the disease is worsening, then you can go for which drug? Mepolizumab, okay, which is the drug which we have already learned against interleukin 5. Now, if there are poor prognostic factors straight away in the Churg straws, it is an indication that you have got to be aggressive. Aggression has to be there. So there you have got to have a cyclophosphamide also along with steroids. Remember I told you, the more aggressive the disease course is, not only the steroids. Remember the first dose of steroids that you give often would be a methylprednisolone pulse. Okay, that is, you can initially think of giving a IV methylpred 1 gram IV for 3 days and subsequently oral steroids. So that applies to any vasculitis with an acute presentation. Initially a methylprednisolone pulse and subsequently the methotrexate or azathioprine. Again, refractory cases, I have told you, we will go for mepolizumab. Okay, because you cannot put the patient on long-term high-dose steroids, which is why a steroid sparing agent like methotrexate or azathioprine would be required. So that's about Churg straws vasculitis. So always remember, what is the most common cause of mortality? Myocardial involvement. Okay. Now coming to the GPA as well as microscopic polyangiitis. The discussion of the treatment, you can discuss it together depending upon whether it is an organ threatening GPA or not an organ threatening GPA. So if it is a non-organ threatening GPA, if the manifestations are not severe, you can go for steroids either alone or steroids with methotrexate. And if the patient is having remission, you can think of tapering the dose of steroids. Okay, and you try to keep the patient on methotrexate and low dose steroids. But if the patient is going for a refractory stage, here again, you can either introduce drugs like RTX, which is your rituximab, or you can go for drugs like cyclophosphamide or maybe azathioprine. Okay, so which means you will have to step up your treatment. Okay, so you will always start with steroids in with diseases which are not that life threatening, vasculitis which is not life threatening, but if needed you will have to bring in your stronger weapons. Remember, cyclophosphamide in vasculitis is always a strong weapon that you have. So if at all you have suspicion of a high disease activity, never hold back on starting cyclophosphamide. Okay, but yes, if it is a young female planning marriage, you know that there can be gonadotoxicity associated with your cyclophosphamide. So before starting, over enthusiastically starting a cyclophosphamide, get the necessary consent also. Especially in today's era, you have got to give the patient or the relatives necessary advice on, see, this is a drug which I am trying to give you. This at present your disease condition is severe and this is one drug which is useful in this. But the problem is there is a small risk of a gonadotoxicity, and take a patient consent also for that. Okay. Otherwise, you might land up in trouble because the patient, you might have saved the life of your patient, but you might be risking your own life. Okay. The patient might say that, doctor did not tell me about the fertility issues. If he had told me, I would have rejected this drug and opted for some other drugs, say like a rituximab. Some other doctor would have said that, rituximab is one drug that can be used. So then starts the issues. Okay. So life-threatening diseases, always steroids in combination with cyclophosphamide. Also, you can go for rituximab also in life-threatening or severe organ involvement. So if there is a remission, you can think of tapering the doses. But again, refractory cases, you will have to choose the other agent. Suppose you started with cyclophosphamide and steroid pulse, you can think of adding rituximab as well. So that is the dosing that you would give. So just again coming back to what I said, always if it is a disease which is milder and can associated vasculitis, go for steroids. Severe presentation, steroids plus cyclophosphamide, and especially in GPA as well as microscopic polyangiitis, you can try rituximab also for aggressive diseases, and for Churg straws you can try mepolizumab also for aggressive disease presentations. Okay, and then finally one flowchart on the small vessel vasculitis, just a small classification to make things simpler for you. As small vessel vasculitis, you have your ANCA associated vasculitis and the non-ANCA associated vasculitis. If you have a granuloma, it is likely to be either Churg straws or Wegener's. No granuloma, it is microscopic polyangiitis. If asthma and eosinophilia are there in the clinical features, then this is most likely a case of Church-Strauss syndrome. Okay, so that is how you deal with the ANCA-associated vasculitis. Non-ANCA-associated vasculitis we will be discussing separately. Okay, so after the ANCA-associated vasculitis, we will now move on to the immune complex mediated small vessel vasculitis. Immune complex mediated small vessel vasculitis. Okay. Now the immune complex mediated small vessel vasculitis, let us see what are the entities falling into this group. You have the IgA vasculitis, which is also referred to as Henoch-Schönlein purpura. Then you have the Goodpasture syndrome. Okay. Next is the cryoglobulinic vasculitis. And then you have the cutaneous leukocytoclastic vasculitis. So these are the entities falling in this group. So we'll first start with the IgA vasculitis, okay, and then after that we'll discuss the cryoglobulinic vasculitis as well. Goodpasture syndrome I have covered in the nephrology module, okay. So let's see the immune complex mediated vasculitis, the first one being the IgA vasculitis or the HSP. So IgA vasculitis or HSP, the age group of affection is age group 4 to 7 years, but may be seen in the adults also occasionally, but classical age group is in the 4 to 7 years group. It is slightly more common in males compared to females, okay. And see, this vasculitis is in fact the commonest vasculitis in case of children, okay, often more than the Kawasaki disease, okay. Some textbooks gives Kawasaki disease as the answer, but it is the HSP that is the most common vasculitis among children. So how does IgA vasculitis clinically present? Okay, clinical features. So clinical features of IgA vasculitis, the most common feature which is almost present in all patients is a purpura, okay. And remember, this purpura will be a palpable non-thrombocytopenic purpura. So a better way of putting it is a non-thrombocytopenic and a palpable purpura. Okay, non-thrombocytopenic palpable purpura you get in case of IgA vasculitis. And very interestingly, this purpura that you have in HSP, they are predominantly located in the region of the buttocks and the extensor aspects, okay, buttocks as well as the extensor aspects, okay. So I'll just show you an image, okay. This is the HSP purpura which is located over the buttocks as well as the thigh, back of the thighs, okay. So that is the most common manifestation. So almost everyone with a HSP vasculitis would have a purpura, okay. And remember, there is no associated thrombocytopenia, because normally when you talk of the word purpura, this is likely to be due to a platelet deficiency or a dysfunction, okay. But here it is a non-thrombocytopenic purpura, and around 70% of individuals will also have GI symptoms. So GI symptoms may be there in 70%. And what are the GI symptoms in this disorder? You may get nausea, you may have vomiting, you may have colicky abdominal pain, okay. And sometimes you can even have blood and mucus passing in the stool, okay, blood and mucus in stools. And you may have constipation, sometimes you may have diarrhea, okay. So these symptoms may be there in as much as 70% of patients, okay. Then you may also have, and remember the acute colicky abdominal pain, that is a characteristic clinical presentation. A child, say around 6-year-old child with a colicky abdominal pain, on examination you get a purpuric lesions over the buttock region. Your diagnosis is going to be a IgA vasculitis. So this colicky abdominal pain is also referred to as a bowel angina. Okay, it is also referred to as a bowel angina. So these are the GI symptoms that you might get in a patient. Now next, coming to the renal manifestations. Renal manifestations. So renal manifestations, you can get glomerulonephritis. Glomerulonephritis. Usually the glomerulonephritis associated with the HSP is mild. Okay, but some cases you can have a RPGN and can go for renal failure, but otherwise most of the cases are having a mild glomerulonephritis. Okay, that's it about the renal involvement. And you may also have arthralgia or arthritis. Okay, arthralgia or arthritis in HSP. Okay, so these are the important features. Let's have a look at the diagnostic criteria of the ACR. It's old criteria, but it is again still followed. The most important features, palpable purpura, age of onset less than 20 years. We know it is roughly around 4 to 6 years. Bowel angina and biopsy. See, you can do a biopsy, and from where do you do a biopsy? You commonly do it from the skin. You can do a skin biopsy. And what does this skin biopsy show in a case of HSP? It shows a leukocytoclastic vasculitis. Leukocytoclastic vasculitis with deposition of immunoglobulin A and the complement C3 in immunofluorescence. Okay, so that is your skin biopsy finding. Okay, and you will also definitely get the granulocytes as well in the vessel wall, but in immunofluorescence it is IgA and C3 deposits that you look for. Skin biopsy is what you would take for this patient. Okay, so I hope the clinical features are very clear to you. Now after the clinical features, the diagnosis, we have just discussed the ACR criteria. Okay, so it's almost always like a clinical diagnosis. Okay, and how will you treat patients in whom you diagnose IgA vasculitis? The treatment is steroids. You would start at a dose of around 1 mg per kg per day, and then slowly in due course you can taper the dose of steroids. Okay, so that is how you will treat IgA vasculitis. Okay, very clear. Alright, so next in the group of immune complex vasculitis. Okay, because these vasculitis which we are discussing now are mediated by immune complexes. In HSP also what happens is that there is often a triggering antigen, which is probably an infection or some drugs or maybe some food. Okay, so all these can act as triggering antigens, and subsequently you have a immune activation and immune complex formation. So IgA is the dominant antibody and the immune complex deposition is what causes the disease. Okay, so next one, cryoglobulinic vasculitis. We are skipping good pastures because we have dealt it in nephrology. So cryoglobulinic vasculitis. So first of all, what are these cryoglobulins? See, cryoglobulins are cold precipitable immunoglobulins. Okay, what are cryoglobulins? They are cold precipitable immunoglobulins which can either be monoclonal or polyclonal. And these cryoglobulins are associated with vasculitis. That is when you call cryoglobulinic vasculitis. Another term for your cryoglobulinic vasculitis is essential mixed cryoglobulinemia. Okay, mixed because it often has a mixture of the monoclonal and polyclonal types. Now let us see what are the types of cryoglobulins, because often the cryoglobulinic vasculitis is occurring because of an underlying problem. Okay, so let's see the three types of cryoglobulins. Okay, type 1, type 2 and type 3. So it's very simple. The type 1 is predominantly a monoclonal. Okay, so it's either IgG or IgM, monoclonal antibodies. Type 2 is having both monoclonal and polyclonal antibodies. You have a polyclonal IgG and monoclonal IgM. Type 3, it has predominantly a polyclonal one, IgG as well as IgM. Okay, so 1 is monoclonal, 2 is monoclonal and polyclonal, 3 is polyclonal. And the type 1 is the one which is associated with multiple myeloma and Waldenstrom's macroglobulinemia. That is, the cryoglobulinemia will be associated with this disorder, like a multiple myeloma. Patients with a multiple myeloma developing a vasculitis could be a cryoglobulinic vasculitis. And type 2 and type 3 have similar etiologies. Okay, though in one it is a mixture of monoclonal and polyclonal, and the other polyclonal. Both the etiologies are same. That is, your hepatitis C infection, maybe certain other infections also, Sjogren's syndrome and SLE. You can see the same reasons for type 3 as well. And another interesting fact to note is that most of the cryoglobulins, okay, whenever there is a cryoglobulinemia, you will get a rheumatoid factor positivity as well. Except in case of maybe type 1 where you may not get, type 2 and type 3 is associated with the positive RA factor. Okay, so that points you have got to know regarding cryoglobulins. Now coming to the clinical features of cryoglobulinic vasculitis. Okay, clinical features. So clinical features of cryoglobulinic vasculitis, it varies. Okay, so here also you can have involvement of multiple systems. You can have cryoglobulinic purpura. Okay, you can have a purpura which is again a palpable purpura. You can have a palpable purpura. You may have a renal involvement, but the renal involvement associated with the cryoglobulinic vasculitis is often a MPGN. Okay, membranoproliferative glomerulonephritis. And you can also have arthritis. Okay, you may also have arthritis. You may have arthritis or arthralgia. You may have weakness. Okay, so purpura may be there, arthralgia will be there, weakness will be there. You can have associated peripheral neuropathy. So these are the important clinical manifestations of a cryoglobulinic vasculitis. Okay, and remember, they are often associated with infections like hepatitis C. If you are asked a question, what is the most common infection associated with the cryoglobulinic vasculitis, your answer has to be hepatitis C. So what about the treatment of cryoglobulinic vasculitis? You can go for antivirals if the possible etiology is hepatitis C. You can also try rituximab in cases of cryoglobulinic vasculitis, has shown good response, and in some cases you might go for steroids. Okay, some cases you might go for steroids. Okay, if it is not responding, you might go for steroids. So this is the treatment of cryoglobulinic vasculitis. Okay, so you have seen the IgA vasculitis and the cryoglobulinic vasculitis. Then cutaneous leukocytic vasculitis, it is a dermatology topic. Okay, but again, see, it is again a leukocytoclastic vasculitis like your HSP. Okay, so it is similar. So that's it about the immune complex mediated vasculitis. Okay, a very important topic, short topic, just a few MCQs, but you have got to learn it well. So finally, after the immune complex mediated vasculitis, we are moving on to, you remember we had a separate term called as a variable vessel vasculitis. Variable vessel vasculitis, in which you had two disorders. What were they? You had Behçet's disease and what? Cogan's syndrome So we'll just discuss a few points on Behçet's. Behçet's again is a very important question. Okay, so just because we are at the fag end of the module doesn't mean that these are less important topics. Behçet's is a very important question that you may get. So Behçet's. So Behçet's disease, again a multi-system vasculitis. It is a variable vasculitis because it can affect the small vessels, medium vessels or large vessels. So it is a multi-system disorder. Okay, and this vasculitis is now grouped under the variable vessel vasculitis, and this is characterized by oral and genital ulcers, oral and genital ulcers, oral and genital ulcers. Also, you will have ocular involvement, ocular involvement. Okay, so these are the cardinal manifestations. You have other manifestations as well, but predominantly you have oral ulcers, genital ulcers and ocular involvement. Okay, so when I talk of the manifestations, one thing is I've already told you they can have oral and genital ulcers. Second is that in ocular involvement, see, they can have a uveitis, they can have a uveitis, so they can have a episcleritis or scleritis, episcleritis or scleritis. Okay, so they may also have manifestations corresponding to other organ system involvement. They may have a CNS involvement where it is called a neuro-Behçet's disease, neuro-Behçet's disease. Okay, so where they can have involvement especially of the brainstem. Okay, brainstem involvement can be there in neuro-Behçet's, especially the region of midbrain. Okay, you can have a vasculitis affecting there, and then you can have a venous affection where you can have either a superficial thrombophlebitis, or a deep venous affection. There may even be a deep venous thrombosis. Okay, deep venous thrombosis. So these are some of the important manifestations. So let's have a quick look at the manifestations of the Behçet's disease. I told you mucocutaneous most important. You can see that oral ulcers are almost seen in 100% cases. You can have genital ulcers, erythema nodosum like lesions, papulopustular lesions, and Pathergy test. We'll be coming to that later. The ocular manifestations, uveitis, keratitis, episcleritis, optic neuritis. Okay, so lots of manifestations can be there pertaining to your eye. Then you can have the superficial thrombophlebitis, deep venous thrombosis, neurological involvement. I told you CNS, especially the brainstem. GI involvement, sometimes having chronic diarrhea and mucosal ulcerations. And yes, they can also have arthritis and arthralgia. So these are the important clinical features of Behçet's disease. But most important are the mucocutaneous, ocular and the neuro-Behçet's disease, and also the venous affection, the venous thrombosis, because all these can translate to clinical scenarios. Okay, you might have a patient presenting with recurrent venous thrombosis, okay, a deep venous thrombosis, and subsequently you might be given in the question that a patient has a oral ulcer, and you might be asked what is the probable diagnosis. Okay, all right. So you see here a patient with Behçet's. You can see the ulcers in the lips. You can have in the tongue. Okay, these images are taken from Kelly's textbook. So you can also have the genital ulcers. Okay, genital ulcers can be there. So next, another important test that I am going to discuss with you is called the Pathergy test. Okay, Pathergy test for Behçet's disease. So what is this Pathergy test for Behçet's disease? See, it is one test that is useful in diagnosing Behçet's disease. Simple one. All you do is that you take a blunt hypodermic needle. Okay, you take a blunt hypodermic needle and then you insert it to the skin. Okay, a blunt hypodermic needle at an angle of around 30 degree, okay, to the horizontal. You insert it tangentially to the skin. And then just that, okay, and then what happens is that after another 24 to 48 hours, you take the reading. Okay, reading means you look at that spot. Ideally, when you give a prick, okay, with a needle, the recommendation says that you have got to give 4 pricks. That is, at 4 different regions you are pricking. It is for you to appreciate it better. You can even give 3 pricks. Okay, and then you look at that site after around 24 to 48 hours and you look whether there is any papule or pustule formation. Okay, so the presence of a papule or pustule formation is a positive Pathergy test, and that is indicative of Behçet's disease. It's a simple test that anybody can perform for a patient suspected with a Behçet's disease. You see here, this is one individual in which you can have a positive Pathergy test. At the site of puncture, you have the papules and pustules developing. Here they have pricked 3 times, you see here. I told you ideally you can go for 4 also. This is for better appreciation. Because if you just poke once, if you see a small pustule, if you have some doubt, is this actually a pustule or is it maybe the small erythema that I am seeing because of my prick? So positive pathology test is again very important. And regarding the diagnosis of Behçet's disease, you have a criteria. It's nothing but a summation of what we have said so far. That's called the international the criteria for Behçet's disease. Okay, international criteria for Behçet's disease. So it is based on a scoring system, and a diagnosis is made when the score is more than or equal to 4. 2 points are given for the oral ulcers, genital ulcers and the ocular lesions, which is why when I described the disease, I was talking of these points as the cardinal manifestations. And you can also have 1 point for the skin lesions, neurological lesions, vascular manifestations and pathology test. So pathology test is having 1 point. So you add it up, and if the total scoring is more than or equal to 4, you can say that this is a Behçet's disease. Okay, so these are the clinical manifestations of Behçet's disease. Okay, see, this Behçet's disease is actually, it is said that you remember when I started off this module on rheumatology, I told you there are 2 groups of disorders: auto-inflammatory disorders and autoimmune disorders. Okay, now this particular disorder is said to be in the crossroads of your autoimmune and auto-inflammatory disorder. Okay, so it is almost having certain features of auto-inflammatory disorder, certain features of an autoimmune disorder. For your exams, auto-inflammatory disorders are not that important, but autoimmune disorders are the ones which we have discussed in detail. Okay, the connective tissue diseases. So this is almost having features of both. Okay, and understand that a few points on the pathology of this disease. This is actually a perivasculitis. Okay, this is a perivasculitis in which you have early neutrophil infiltration and endothelial swelling. Okay, these are some important pathological changes that happen. And in case of Behçet's disease, you will have certain antibodies as well. Okay, so you will have antibodies as well, and these antibodies are targeted against certain antigens. So just know the name of the antibodies. You have the antibodies against the Saccharomyces cerevisiae, which is called ASCA, anti-Saccharomyces cerevisiae antibodies, ASCA antibodies. You have antibodies to the selenium binding protein, and also you have antibodies to enolase. Okay, this is something that is present on the antigen that is present on the endothelial cells, which is why you remember I told you there is a endothelial swelling that occurs in your Behçet's disease. So some points with your pathology of the Behçet's disease. Now how will you treat Behçet's disease? Treatment of Behçet's disease. Treatment of Behçet's disease depends on the manifestations. Okay, so if you have predominant, say, a mucocutaneous manifestations, you can go for topical steroids. So topical steroids, you can go for the mucocutaneous manifestations, that is your oral ulcers, genital ulcers. Okay, you can go for that, mucocutaneous manifestations. And but if it is severe, okay, suppose if the mucocutaneous manifestations are severe, then you can think of thalidomide. And if along with the mucocutaneous manifestations, okay, mucocutaneous plus you have arthritis also as a manifestation, then colchicine is a preferred agent. And what about the role for oral steroids or systemic steroids? Systemic steroids, predominantly 2 indications in Behçet's. One is in uveitis and second is in Behçet's disease, neuro-Behçet's disease. And another point that you have got to know is that, see, I told you this disorder is characterized by a perivasculitis, correct, no? But sometimes it can involve the vessel wall entirely and it may produce pseudoaneurysms. And it is known to produce pulmonary aneurysms, okay? So, if at all pulmonary aneurysms occur in Behçet's disease, remember they are a rare finding, but if at all pulmonary aneurysms occur, then you can think of giving pulmonary aneurysms, you can think of giving cyclophosphamide. Okay, in that case you can give cyclophosphamide. Now this is an interesting feature, okay, this pulmonary aneurysms, because in the vasculitis which we have discussed so far, we have never discussed pulmonary aneurysm. So this is one vasculitis that can produce a pulmonary aneurysm. So this is very important. So that's it about the treatment of Behçet's disease. Now finally we'll go to the next variable vessel vasculitis, that is your Cogan syndrome. Just a fact that you have got to know is that Cogan syndrome is a variable vessel vasculitis in which you can have an interstitial keratitis that is associated with audiovestibular symptoms. And by audiovestibular symptoms means like you can have vertigo, okay. So that is what is this Cogan syndrome. All you have got to know is just that about Cogan syndrome. So we have seen in detail regarding the vasculitis, the Chapel Hill Consensus Conference, the various types of vasculitis. So Kawasaki, we have left it for the pediatrics module. You can see in the pediatrics module. And then good pastors go back to the nephrology module, okay. So rest of that we have discussed in detail. So it is very, very important for your exam. As I told you, just keep revising it, make tables so that you don't mess it up, okay. There is a chance that when you learn, you might mistake a microscopic fan for a polyarthritis nodosa. But if you revise systematically and after listening to this module, just revise it once again. You can listen to this module maybe watch it at a higher speed, and then that will make things very simple for you, okay. Very important module on vasculitis.